Take Back Your Health Now, Episode 78.
You're listening to the Take Back Your Health Now podcast, the show that interviews the top doctors, athletes, trainers, and entrepreneurs to help you find the holy grail of health. Now here's your host, Dr. Dan Margolin.
This is Dr. Dan Margolin with another segment of Take Back Your Health Now, where we pull out all the stops in search of health's holy grail. We're real excited to have Dr. Zach Gross. He is an accomplished medical doctor, published author, and internal medicine resident physician at Florida State University College of Medicine. He cut his teeth as an ice hockey player in Washington, D.C., and went on to play junior A hockey in Syracuse, New York, and Boston, Massachusetts. Following his junior hockey days, he attended the University of Arizona and Curry College, where he graduated magna cum laude in public health with a minor in biology. Zack then pursued clinical research on thyroid cancer at Washington Hospital Center. Feeling compelled to get more involved in medical research, he spent a year at the Institute for Myeloma and Bone Cancer Research in West Hollywood, California, as clinical research analyst, and published various research papers on multiple myeloma, two of which Zack was a first author on. He attained his MD from Ross University School of Medicine. Zachary Gross, how are you, sir? Welcome to the show.
I'm good. Thank you for having me.
No, I'm excited to speak with you. So, Zack, just, go back to, take us back to the beginning. How did you get involved in medicine? How did you get involved in hockey? Tell us a little bit about that.
Medicine came later for me. Hockey was pretty much my life as a kid growing up, and decided that I really wanted to try and take it somewhere. Eventually I started playing on some pretty good hockey teams in Washington D.C. and then I started looking to get out of the area and go up north and play, and eventually possibly get a scholarship to play hockey for college, or even someday play professional hockey if that was feasible.
Right.
Once I started, getting better, and, I started getting, some opportunities, boarding schools were looking at me. I was teams up north, as you mentioned in my bio. And eventually I went up to Syracuse, New York. And they offered me a contract up there, and, things kind of catapulted, and I spent another year after that, playing in Boston. But, in that 2-year span, I had 5 knee surgeries. So it kind of threw my career off track.
Wow. What happened?
I had and the rest were meniscal repairs. So,
Wow.
I was a pretty hard-nosed player. I would hit a lot. I would fight. I wasn't the prettiest goal scorer kind of guy.
Right.
I was a 5'7", 190 pound, fast guy that liked to, be in your ear the whole game, and
Wow.
trying to annoy you. So, yeah.
Wow. So that is that what sort of ended your career?
It just got to the point where I realized that this isn't really going to go any further than playing some college hockey, and I just have to accept that. And everybody's got a dream, and sometimes it works out, sometimes it doesn't. You work the hardest that you can, and when it doesn't, you accept it, you move on, and you say, hey, I want to go do something else now. And luckily, I was able to, I got out of hockey for a bit. I got really interested in yoga and a lot of Eastern medicine therapies, and some non-traditional stuff, to be honest. And it was when I was at the University of Arizona, which once I decided not to play anymore after my year in Boston. I was 20 years old, couldn't play anymore. What am I going to do now? So I applied to University of Arizona. I went out there. I spent my freshman year not playing hockey, and just kind of, being a normal person again, and just, doing regular things like socializing, and, I wouldn't be traveling every weekend. I get to spend more time with friends. I got sick of not being an athlete for a year at Arizona. So then I decided to play another year of hockey for the team at University of Arizona my sophomore year.
Huh.
Turns out I tear another meniscus in my knee, I break my wrist, and that's and that's when I started getting into yoga and Eastern medical therapies and things like that, because
Sure.
I was being way too hard on my body, and did in non-traditional methods of medicine. And I ended up transferring to a small school in Boston my junior year of college, which was Curry College. And I started taking anatomy and physiology courses, biology, chemistry, and I was doing really well. And a lot of my professors were telling me to apply to, regular allopathic, Western medical schools. And, at first I said, I haven't been doing this, my whole life, like, getting straight A's and everything. And
Right.
But they said, but you're our best student here, and all you're doing is getting A's now. It doesn't matter what you did in high school and in, middle school and whatnot. So,
Wow.
yeah, so I went from there, and I ended up graduating magna cum laude, public health major and a minor in biology. And, that's how I started applying to medical schools and to med school. And, here I am now in residency, which is a whole different animal in and of itself. So,
I know when I did my residency, it was rough. It was a rough year. It was the podiatry surgical residencies back there were 1 year. And I think I lost like 10 pounds. I don't think I slept at all. Is it sort of like that?
There's now some restrictions, I'm sure you've seen those in the media, they're not doing there were some restrictions for first year residents that they couldn't do more than, I think it was like more than 80 hours a week or something like that.
I remember there was like someone that was a hospital in New York. A resident had been up for like many days, and there was some injury or something like that with a patient. I do remember there's a whole lawsuit over that. Yep, I do remember
so
that.
There's been a lot of legislation over this, and they actually just came out with some new data that shows that there's really not any adverse outcomes when residents aren't when they're if they're working extended hours, there's no adverse outcomes for the patients. So they're kind of going back to the longer hours now, but residency hours have always been long. You're up at 4:30. You're get into the hospital, you see your patients, you do your notes, then it's morning report, and then you round on patients, and then you got the rest of the day to discharge patients, to update their notes, look at their labs, replace anything that needs to be replaced, treatments, whatnot. So, it's a challenge for sure. It's definitely, it's hard. Being able to talk to you today at 5:30 is like pretty awesome because I don't even get a second at 5:30. So.
Oh, good. I'm glad. Well, thank you for taking the time. I appreciate it. Well, let me ask you, so how did you get into doing the research on multiple myeloma and thyroid cancer and things like that?
So after I graduated undergraduate, I was going to have some time off, and, applying to med school, you got to take your MCAT. Sometimes it's good to do research. There's a ton of people applying. There's thousands and thousands applying for 200 to 400 spots each year. So.
Wow.
It's hard to get into med school. It's just the way it is.
Yeah.
I thought I came from a bit of a non-traditional background, where I started, my second year of college, really looking into this stuff instead of from the beginning saying that I was going to be pre-med. So I thought I really needed to strengthen my application a bit and, do some research and, network a little bit and, see who I can meet and, what it's going to be like being around residents and med students in the hospital. So
yeah.
I ended up doing papillary thyroid cancer research at Washington Hospital Center in Washington, D.C. with the chief of endocrinology over there and one of the endocrine surgeons. And, they kind of took me under their wing, and I started learning the basics about research. And it's like a whole new language. It's still tough when I'm going through stuff. It's just because you don't do it every day. And unless you're doing it every day, it kind of leaves you a little bit. So I started there. I was spending a lot of time, reading research articles, writing protocols, and this all seemed like a totally different language to me. And and then I eventually applied to med school. I got in, and then I finished last year in not this past May, but the May of 2016. And it's funny, I originally wanted to go into OBGYN and get involved in fertility, endocrinologist. And I had a mentor who told me, go do research for a year. It's really competitive. Try try and buff up that, your application more. And I said, all right. So I got a great position with a world leading oncologist in multiple myeloma in California. And I worked with him for a year, and I did data analysis. I wrote protocols. I even did medical writing and wrote papers. And then finally, I got into residency on my birthday of all days. It was match day this year.
Oh, great.
Yeah. So that's kind of how the research worked for me. My first go around in research, though, I didn't really get to publish too much. I published 2 papers last year, and then I have another one now that, as a first author, that I've submitted, that just kind of fixing up the edits on it, and that should be getting out pretty soon.
Okay.
So it was a real honor to be able to finally become an author,
Yeah, no, Dr. Gross, let me ask you, just in the research that you did, we're not going to go so much into cancer this time, though maybe we'll have you back on to go into more on that. But was there anything shocking or anything that changed your viewpoint regarding cancer, having done all of that research?
I think the most shocking thing wasn't so much about cancer per se. I mean, you know how complex cancer is, and we're learning new things every day. But honestly, like the process of medical research is the thing that really just said to me, like, whoa, there's so much that we do not know. After going through, learn a ton about research. When you talk to these people that have PhDs and in neurology and things like that, and they spend their lives doing research and writing papers and doing hardcore bench work in the lab, it's a totally different world. And you do find out that there's so many things that you never get taught about in med school that are involved in research. And I think that was the most mind-blowing thing for me, but it was also extremely helpful because now I can read literature and I know what they're talking about when they're talking about confidence intervals, when they're talking about, mortality ratios, things like that.
Right, I imagine that can help you a great deal as you're starting to study other things, other mechanisms. One of the things you said that I thought was interesting is that you at one point got into somewhat of a non-traditional philosophy of medicine, and then now you're in medical school, went through medical school, you're in your residency. When you compare the non-traditional stuff that you learned, tell us a little bit about that, and then tell us how that compares to what you've learned through medical school and in your residency.
Well, when I mentioned, that I ended up playing one more year of hockey over at Arizona and I broke my wrist and whatnot, I was a certified personal trainer at the time. I was a major in nutrition and dietetics. I wanted to get involved in training athletes and, possibly being a nutritionist for athletes. And that was what I was really interested in. And when I couldn't work out, anymore with that, I'm going to go try yoga. And, I really got into it for the physical side of it. And then it kind of just, it blew up into something that became hugely spiritual for me.
Wow.
Yeah. And I did my life did a total 180. I just completely changed as a person. My lifestyle changed. Not that it was bad before, but, yeah. So
it is funny though. A lot of times when you do speak with, medical doctors, the spiritual, just even hearing anything spiritual is never brought up, right? It's not something that it would commonly be brought up, I imagine, in a hospital setting that much, but correct me if I'm wrong about that.
Yeah, no, I mean, it's considered foreign, really, in Western medicine. It's kind of getting more, it's getting more accepted now, but, I found a mentor out in Arizona who ran a yoga studio. I did a whole, 60-day program of like journaling and meditating and doing and vegan and all this cool stuff. And it worked wonders. I was just like, I was the most grounded human being, that I ever have been. And, when I left and went to Boston to transfer colleges, still doing all that. And then the minute someone said, you're smart enough to go to regular med school, Western medical school, and I just went for it. And what's interesting is I kind of dropped all of the, spirit things I was doing for myself. And, I saw that change. I saw what happens when you do that. and I became extremely competitive. I'd say I wouldn't take care of myself as much as I did before, with the approach to yoga and whatnot.
Right. Well, you're sort of, I mean, I got to imagine in medical school, as in the residency, it's a little bit of a survival kind of thing, right? You're trying to pass the test. You're trying to learn everything. I mean, it can't be a very easy experience for you.
Yeah, it's this really long road, and you never know what you're getting yourself into. And it has been so great. I have loved it. But the amazing part about the journey is that there's something totally new that comes up like every other couple years in your training that you didn't know about, because you have to be in it, experience it. And
right. Yep.
Yeah, like the MCAT, that is a super standardized test that, some people can just take that thing and they can crush it. And some people can study for years for that and just, not do that great. And that's your entry into med school, aside from your grades. And, so I applied to the schools that I wanted to get into. I didn't get into the schools I wanted to get into. And then I had a decision to make, and I applied to a school in the Caribbean. And I was going to leave my friends and my family, and it was going to be with all American and Canadian students. It wasn't going to be like I was going to be like the only American person on the island. And I went there, and it was a very competitive environment. I had a wonderful experience. But yeah, it's all about how you do. It's all about how you get evaluated by your attending doctors. It's all about, it's really all about your board scores. It's your standardized test. That's what it comes down to.
No, I remember even in podiatry school, when we had to take our final boards, we'd been training for 4 years or 3 years for the most part, because it was in the last year. And they said, okay, good. So you've got the boards coming up. Here's the information you need to study for them. And it was completely different than what we had studied for the last 3 years. And I remember thinking, what the hell were you teaching us for 3 years? Where did that even come from? So did you have a similar experience?
Yeah. And, you get to med school, you get off in your first day, you're like, oh my God, how am I going to learn all of this? Like there's no way.
Right.
And, so you have that part, and then you have the boards, which are totally different than some of the things they teach you in class. And yeah, there's always something you don't know that someone else does know.
Yeah.
So yeah, I totally understand that part of the experience. And then you start residency, and it's all clinical. And clinical medicine is totally different than what you read in the books. Like what you do in person is totally different. I'm sure you've been through this a ton.
Sure. Well, tell us, so from a clinical perspective, the types of patients that you're treating, what are they? I know you've done the research in the cancer area. What are you, on a day-to-day basis, what type of patient, what type of disease states are you seeing?
Well, I mean, it's interesting because, we have different rotations in residency. So, we have rotations where we're on the floors, like the wards in the hospital, which, can be anything from, someone coming in with, diabetic ketoacidosis because they're non-compliant with their diabetes medications, to somebody with, congestive heart failure or a heart attack. But, then the next week you could be in hematology oncology, and you have patients with breast cancer, and, you're learning about the treatments and the genetics and which genetic markers have more favorable prognosis versus the other ones. I also I do outpatient work also, where I have a clinic and have my own patients there, and I follow them long term. So just, normal physicals, follow-ups after hospitalizations, things like that. So, but I would say, right now I am on my floors rotation, and I am either admitting patients that come into the ER that the ER decides that they need to come in. And that could be someone with a super low hemoglobin who's super anemic, to someone who had a heart attack, like I said. So
Right.
Real bread and butter medicine. And the bread and butter things are like COPD, which is chronic obstructive pulmonary disease, myocardial infarctions, which are heart attacks, diabetic ketoacidosis, which is, due to, a reaction to having, too high of blood glucose, and you eventually get acid, dehydrated, and you get electrolyte abnormalities.
And Doc, when you're looking at the diabetic ketoacidosis, like over what length of time are we talking about? How long does it take for somebody with diabetes to actually develop something like that?
Well, most people that are on diabetes, if they're being followed up by their physician, and it's not even about whether to be followed up by their physician. It's about, are they being compliant with their medication? So I wouldn't say there's a set time to go into diabetic ketoacidosis.
Mm-hmm.
It's just whenever your cells in your body cannot use the glucose in your blood because they're you're so insulin insensitive, or there's not enough insulin in the body to get that glucose into those cells that need it for energy production of ATP. That's when it happens, because your body has to use other types of fuel like fat and
so your body's in search of a fuel mechanism. Dr. Gross, go over the two types of diabetes, like what causes them, if you would, just for the audience.
Yeah, so we've got type 1 diabetes, which is an autoimmune disorder of destruction of the pancreas, and the pancreas is what produces insulin. And there's cells in the pancreas called beta islet cells, and those are what produce the insulin. And there's some antibodies in type 1 diabetics that cells which end up killing them, and eventually you have no more pancreatic beta islet cells to produce insulin anymore. So those patients are completely dependent on exogenous insulin.
Now, are these patients typically born with this?
Yeah, it can be. It's funny. A lot of people think type 1 is more genetic than type 2. And I'll go over type 2 in a minute, but it's actually the other way. Type 2 is more genetic than type 1. Huh. You can be born with it, but it can also develop, a few years, later on. How there's specific triggers that turn on genes and whatnot.
Sure. What would be some triggers that would do that?
Oh, it could be anything. I mean, sometimes when you get stressed, that can turn on a trigger for a cancer gene. That can turn on a trigger for any autoimmune disease.
Right.
Sometimes all it takes is that one stressor. It could also take an infection, something like that, something that changes your physiology in some kind that causes a stressor on your body that can just turn that switch on, and you could have that, those first symptoms, and you go in and, sure enough, you get diagnosed with, type 1 diabetes. But, yeah, so
it's interesting. If there is a trigger or something like stress, it would also make sense too that there would be ways to sort of avoid hitting those triggers, if you would, right? So in other words, there would be certain things that you could do to, I guess, avoid putting yourself in those situations. Do you find that to be true?
I don't think we really know. I don't think anybody really has even found that out yet. There's no exact thing that we know that causes one event that will cause you to turn on certain genes for certain diseases.
Well, jump into the type 2, and then I got a couple other questions along those lines to ask you.
All right. So type 2 diabetes is not so much of an insulin production problem. It is due to your cells being too insensitive to insulin. Insulin in the world is a type 2 diabetic, but if you're not getting insulin into, if your cells cannot respond to insulin to get that glucose into the cells, it's no good. And they've actually found that type 2 diabetes is more genetic than type 1. Also, the difference between type 1 and type 2 is type 1 diabetics not obese, whereas type 2 diabetics are on the more obese side or overweight, because obesity and like metabolic syndrome, those are the kinds of things that are associated with diabetes, for type 2 diabetes. I'm sorry.
And, we've had quite a few guests who've actually talked about reversing the type 2 diabetes for somebody that was like obese and, putting them more on a vegan or vegetarian type diet and turning around. I've actually seen that with patients as well. Have you seen that?
I mean, I've seen patients that have completely changed their lifestyle. I mean, the first step in management of type 2 diabetics is weight loss and lifestyle management. We don't say, hey, we need to put you on metformin now, or we need to go put you, on, sitagliptin or something like that, or like any of the diabetes drugs you could think of.
Right.
Yeah. So the first thing for type 2 diabetics is lifestyle modifications and weight loss, and it can reverse it because honestly, exercising causes your cells to become more sensitive to insulin. And that's what it's all about with type 2 diabetics. Your cells need to say, hey, that's insulin. Let's react to it. Let's get the glucose into the cells so we can do our thing.
As a podiatrist, some of the side effects that we see of patients that really aren't treated or aren't taking care of themselves and they have this sugar is neuropathy, where they actually they can no longer feel their feet. Mm-hmm. I've had patients actually burn themselves almost using heating blankets at night because they didn't feel their feet and it just got so hot. I mean, how common would those type of changes to the foot and leg or what other side effects do you commonly see with uncontrolled diabetics?
Extremely common. I mean, I see people with, like you said, they can't feel anything. So you have diabetics out there who are walking around their house, banging their feet into walls, into things that cause injuries to their feet. And then they have sores on their feet that they can't feel because, they have peripheral neuropathies like you're talking about. And then they end up getting gangrene, which is an infection. And then sometimes they need their foot amputated because it's the skin is dead, the tissue's dead. It can cause some really bad stuff if you do not follow up and if you're not compliant with your medications. So I see it all of the time, and I always check. People that have diabetes, I always check their sensory function in their lower extremities for the most part.
And why does it so affect the feet and not the hands, or would you say that it does affect the hands as well?
I mean, that's a very interesting question. I've never actually looked into that. I don't think I've ever seen somebody that has had like peripheral neuropathy of the hands, but not of the feet. But that's not to say
I ever did either. Yeah, I've never seen it myself.
That's not to say that you can't get someone that comes in with, of their hands, which is like burning and tingling and numbness, things along that line. But for the most part, it's always the diabetic foot exam. That is the number one thing you always want to check for, as you know. So it's funny they don't have a diabetic hand exam. I should actually look into that.
I just have never seen it. And usually you tell the diabetic patients typical things like one of the things we say is like when you buy shoes, buy them at the end of the day when your feet are a little more swollen. Have somebody, if you can't feel your feet, a lot of times there's also eye problems that are associated with it. When you get these patients that try to cut their toenails and they can't see and, and they cut themselves and you're off to the races with all these. Do you see the same thing?
Yeah. We get a lot of diabetic retinopathy and, we always make sure that they're following up with their ophthalmologist. To make sure that they're being treated for that if they do have some retinopathy. And a lot of them have cataracts as well because extra sugar, causes the lens of the eye to become clouded and, they have vision problems as you're mentioning. So yeah, we do see that a lot, but that usually gets referred though to the ophthalmologist.
Right. Absolutely. Well, it's interesting to me like that all of these side effects could to some degree be prevented just by really taking care of yourself, really making sure the sugar levels are going. But every once in a while you catch those patients that I don't know if they've given up on life or whatever, or they're just frustrated, but they let it go for years until, you get that disease state. Or sometimes you get a disease where at the beginning, it doesn't show any symptoms. And at the end, the symptoms show up. And by the time the symptoms do show up, it's really at the end stage of that disease. And I think part of, like, I look at my job is just increasing the awareness of these people so that they don't allow it to get that far. Would you say that that's a big part of what you're trying to do as well?
Yeah, I mean, but one of the, I think the hardest thing to deal with in medicine is having patients really understand what's going on and what they really need to do to change, what's going on with them, their disease state. And compliance is always an issue. I mean, when we're writing, when we are documenting, we are always noting whether somebody is complying with their therapy or they're coming to their appointments or not, because compliance is the total key.
If you could have a heart-to-heart, let's say it was a family member that was recently diagnosed with diabetes, what would you say to them?
I mean, I know how hard it is to make changes. So, if I were to talk to a family member about this, I use the approach of, you want to scare somebody a little bit, but you want to make them understand that you're going to have some relapses and it's going to be hard. But, usually I tell them, if there's anybody that I'm close to that I'm talking to about this, what are the long-term implications? Diabetes, especially type 2 diabetics. And when they hear that, and you really kind of get them to understand that it's a scary thing. And, normally we seem to not do anything as human beings, I don't want to say everybody, but a lot of us, until something happens to us. It's like, oh, it's time now. But, you don't want it to ever get to that point. So I definitely use, the complications of diabetes. Those are the scary things to people. And sometimes you have to scare somebody to really get them to understand what's going to come down the pike if they don't listen to their healthcare provider.
Absolutely. Absolutely. Sometimes it takes that little push. One of the questions I always pose to my guests is what they consider to be the holy grail of health. That is the concept of the show, is that's really what we are searching for. So if I were to pose that question to you, what do you consider to be the holy grail of health?
As we were talking about how I used to be involved in, super involved in meditation and yoga and a lot of the Eastern therapies, which are very holistic and, not as Western as, the stuff that, we do in the rest of the world, especially in the United States. I've recently gotten back to really making the decision to take care of my mind, take care of my body, and take care of those around me. Important to me, especially during residency. I'm barely home. You're constantly dealing with life and death situations, and there's something called empathy burnout, where you give so much empathy on a day-to-day basis that you actually get sometimes you can get a little insensitive to it because it gets so hard to deal with.
How has that affected your social life? I mean, I guess that's a tough. That is tough when you're dealing with that all day long, right?
Yeah, I mean, my residents in my program, we're a really tight-knit group. So I guess my social life pretty much revolves around them and obviously my family. My wife and my dog are my outlets. But I'm very lucky to have a great group of residents in my program. And it really, I really enjoy going every morning when it's dark. Yeah, I mean, I know most people will be like, "Oh my God, but you're not sleeping." But it's really a privilege to be there and to finally be a healthcare provider now, and take care of people in their most vulnerable states. And sometimes they tell the doctor what they won't even tell their own family members. So it's.
I think the residency is lucky to have somebody like yourself who obviously is caring, and you've got a whole future ahead of you, and well done, sir. Well done.
Thank you. I appreciate it.
How would, Dr. Gross, how would people that want to get in touch with you, know more about you or what you're doing, how would they get in touch with you?
I usually say the best way is email for me. I used to try and do some stuff on social media and blog and whatnot, but I noticed that with all the responsibilities of med school and all the exams and everything, I kind of got away from it. So my email would be best, and I could provide that right now.
Sure.
It's N as in Nathan, G as in Gross, and 0313@gmail.com.
Dr. Zachary Gross, thank you for being on the show. It's greatly appreciated, and thanks for all your hard work.
Thank you so much. Have a great day.
This episode is sponsored by New Jersey Foot and Ankle Center in Oradell, New Jersey. Remember, when you have a foot problem, you've got a foot doctor in the family. Weekend and evening appointments are available. Call us at 201-261-9445. Once again, that's 201-261-9445. Thanks for listening. Check out the show notes over at drdanspeaks.com. If you're loving the show, head over to iTunes and leave us a review, and we'll catch you next time.